Right now, as you're listening to this, there are about 63 million Americans working a really grueling second job.
Yeah, and a completely unpaid one at that.
Exactly. Unpaid, highly complex, and honestly, physically demanding. I mean, they're acting as project managers, financial planners, pharmacists,
Physical therapists.
right, physical therapists, and transportation dispatchers, you name it.
It's massive.
They're working these totally unpredictable hours, managing literally life or death situations, and navigating incredibly dense bureaucratic systems, all without seeing a single dime.
It is, I would argue it's the most critical infrastructure in the entire American healthcare system, and it's completely invisible.
Totally visible.
Like, we talk endlessly about cutting-edge surgical robotics, right? Or miracle pharmaceuticals.
Oh, yeah. Or those state-of-the-art hospitals with the beautiful lobbies.
Exactly. We obsess over these visible peaks of the healthcare mountain, but we just completely ignore the foundational base camp that makes any of it even possible.
Which is the family caregiver.
Precisely. The family caregiver.
So for you listening, whether you're, an executive trying to understand macroeconomic forces in healthcare, or maybe a clinician trying to figure out why your patients just keep missing appointments.
Or maybe you're in the trenches yourself, right?
Yeah, exactly. Maybe you're currently trying to manage care for an aging parent. Our mission today is to pull back the curtain on all of this.
We are doing a deep dive into the hidden and, frankly, exhausting physical and emotional labor of family caregiving.
And we're doing this by going through a really fascinating, highly detailed body of information compiled by SwiftAid Transport.
Yeah, what we have here from them isn't just, a list of grievances or abstract stats.
Right.
It's a rigorous look at the daily, grinding reality of 1 in 4 adults in this country. That 63 million number, that comes from the AARP and National Alliance for Caregiving 2025 data.
1 in 4 adults. It's just wild to think about.
It really is. But the core thesis we need to explore today is much more philosophical, and it's going to challenge a lot of assumptions for you.
Definitely. What is that core thesis?
The thesis is this: love might be the absolute reason families show up to care for one another, but love does not magically remove the physical and logistical burden of that care.
I think we really need to start right there. Let's look at the psychology of how families even talk about this burden.
Yeah, the language they use.
Right, because there's a very specific linguistic trap that people fall into. The data points this out beautifully. It's what we might call the just trap.
Oh, the word just is perhaps the most dangerous modifier a caregiver can use.
I hear it all the time. Like a coworker will look completely exhausted and you ask them how their weekend was and they say, oh, I was just helping my mom around the house.
Right, or someone leaves work early and says, I'm just running my husband to his cardiology follow-up.
Exactly. It's always, I'm just doing what family's supposed to do.
When a person uses the word just in that context, they are engaging in a very specific type of cognitive dissonance.
How so?
Well, they're actively minimizing their own labor. Society has basically conditioned us to view caring for our elders or our sick family members as a moral obligation.
Which, it is.
It is. But because it's a moral obligation driven by love, we somehow convince ourselves that it shouldn't be counted as real work.
Oh, I see. So if it's done out of love, it doesn't count as labor.
Exactly. By repeatedly telling themselves that it's just a small thing, they prevent themselves from recognizing that they have effectively taken on a second highly demanding career.
Wow.
Caregiving is not merely emotional support. It is intense, relentless, physical, and administrative labor.
It actually makes me think about IT infrastructure.
Okay, go on.
Like if you look at a massive corporate network, you often have a single point of failure.
Yeah.
It's that one random server tucked in a closet somewhere.
Right, gathering dust.
Exactly. And as long as that server is humming along, nobody thinks about it. The company makes money, the emails get sent, the software works.
But the moment it goes down,
The moment that single server overheats, the entire multi-million-dollar operation just grinds to a halt. I feel like the family caregiver is the single point of failure in the healthcare system.
that is a much more accurate framework than simply viewing them as a, helpful relative.
Yeah.
Because if we break down the actual administrative load that's detailed in the AARP and National Alliance for Caregiving data, the sheer volume of tasks is staggering.
It's like an iceberg, right?
Yes. The holding hands, the saying, I love you, That's the 10% visible above the water.
And the 90% below the surface.
That single point of failure is holding up scheduling for multiple specialists, deciphering conflicting medical advice, managing complex medication titration schedules.
Oh man, the medications alone are a full-time job.
Exactly. Plus handling insurance authorizations, coordinating hospital discharges, preparing specialized dietary meals, and monitoring really subtle changes in symptoms.
So imagine trying to do your normal job. You're listening to this, maybe you're an accountant or a teacher or a retail manager. You have your own kids, your own mortgage, your own grocery shopping. And then, virtually overnight, without any formal training whatsoever, you have to also act as a medical coordinator for an entirely different human being.
And you are doing all of this while operating on a massive sleep deficit.
It's just unsustainable.
It is. But of all the responsibilities on that overwhelming list, the data isolates one specific task that operates as the ultimate time consumer.
The ultimate stress multiplier.
Yes. It's the literal bottleneck where the caregiver's capacity physically breaks down, and that is transportation.
See, I want to push back on this a little bit because if I'm listening, I might be scratching my head.
Sure.
We live in a car-centric society. We drive everywhere. What is so inherently difficult about giving someone a ride?
Right. You think it's simple.
Yeah, like you pick them up, you drive them to the clinic, you drop them off. It's driving. We all do it.
Calling it driving is the fundamental myth we really need to dismantle today.
Okay, dismantle it for me.
For a family caregiver, transporting someone with chronic illness, mobility limitations, or cognitive decline, it is never, ever just a ride.
What is it then?
It is a massive, multi-stage, logistical and physical event. Let's actually look at the mechanics of this. Try to walk me through what you think a standard Tuesday morning doctor's appointment looks like for a caregiver.
Okay, sure. Let's say the appointment is at 10 a.m.
Okay.
I wake up, I get myself ready, maybe go to my dad's house by 9 a.m. I help him get his coat on. We walk out to the car. I drive for 20 minutes, park, and we walk into the waiting room.
You missed about 6 critical, physically demanding steps in that timeline.
Wait, really? Where?
Well, first off, the preparation starts much earlier than 9 a.m. When you arrive, you aren't just putting a coat on someone.
Right. I guess that's oversimplifying.
You are likely dealing with morning joint stiffness, medication timing, or perhaps assisting with toileting and dressing, which, for someone with limited mobility, takes a lot of time and physical exertion.
Yeah, that makes sense.
But the critical failure in your timeline is the transfer.
You mean getting out of the house?
I mean the literal physics of moving a human body from a resting position to a mobile one.
Oh, right.
You have to move the passenger from a bed to a chair, or a chair to a walker. You have to navigate the spatial hazards of a standard home.
Like narrow hallways, right?
Narrow hallways, transitions from carpet to hardwood, steps leading down to a garage. Then you have to load a heavy mobility device like a wheelchair or a heavy-duty walker into the trunk of your car.
Okay, I see what you're saying. I completely glossed over the physical environment.
And we haven't even gotten to the hardest part.
Which is?
Putting the person into the vehicle.
Oh, wow. Yeah.
You are trying to help someone with compromised balance maneuver their body into the passenger seat of a consumer vehicle, a vehicle that was never designed for medical transport.
Right, it's just a regular sedan.
Exactly. Then you drive through traffic, dealing with the anxiety of being late. You arrive at the medical complex, but the handicap spots are all full.
They always are.
So you park a quarter mile away. You unload the wheelchair. You assist the passenger out of the low car seat.
Which is another whole physical transfer.
Yes. Then you navigate uneven pavement, steep curb cuts, and these labyrinthine hospital hallways just to sit in a waiting room for 45 minutes because the doctor is running behind.
And when the appointment is finally over, both the patient and the caregiver are already completely drained.
Totally exhausted.
But they aren't done. They have to execute that entire physical sequence in reverse.
Exactly. Getting back to the car, getting in the car, driving home, getting out of the car, getting back in the house.
It's exhausting just talking about it.
Now, let's look at the compounding nature of this. Your hypothetical Tuesday morning appointment took, realistically, 3 to 4 hours of active, stressful labor.
Right.
One appointment in a month is exhausting, but, manageable. But chronic healthcare doesn't operate on a once-a-month schedule.
No, it rarely does. It usually starts with one acute issue, like a fall or a surgery, and then the follow-ups just multiply. Suddenly, it's physical therapy twice a week.
Let's expand on that. Physical therapy twice a week. Add in dialysis, which is often 3 days a week.
Oh, yeah.
Throw in a monthly cardiology checkup, Bi-weekly wound care clinic visits, maybe a trip to a phlebotomist for lab work, and a visit to a behavioral health specialist.
You are no longer talking about a few hours a month.
Not at all. You are looking at 20 to 30 hours a week of driving, transferring, and waiting. It becomes a suffocating full-time puzzle.
And remember, the rest of the caregiver's life does not hit pause during all this.
No, it doesn't. Their own bills need paying, their own boss expects them at their desk, and their own children need dinner.
When you lay it out chronologically like that, you realize it's not just the clock that's ticking, it's the physical toll.
A huge physical toll.
I really want to dig into the biomechanics of this because this is
Yeah.
where the danger really lies, right?
Mm-hmm.
Helping someone into a vehicle sounds benign until you actually have to do it.
The mismatch in equipment and physical training here is just staggering. We essentially expect a 55-year-old daughter who already has her own mild back pain from working a desk job.
Right.
We expect her to suddenly possess the kinetic awareness and lifting mechanics of a trained emergency medical technician.
And an EMT has a partner. They have a hydraulic stretcher and an ambulance with a ramp or a lift.
Exactly. But this daughter is trying to do it solo using a four-door sedan.
It's basically impossible to do safely.
The physics of the standard consumer vehicle are actually the enemy here. Think about the seat height.
Okay, yeah.
If you are using a low-to-the-ground sedan, the passenger essentially has to fall backward into the seat. And to get out, they have to fight gravity from a deep bucket position.
That requires so much core strength that they just don't have. What if they have an SUV?
If you're using an SUV, the passenger has to step up, balancing their entire body weight on one compromised joint while twisting.
And where is the caregiver during this? They're usually bending over at the waist, reaching into the car frame and trying to pull or push dead weight.
Right. Anyone who has ever been to a gym knows that lifting weight while your spine is twisted and bent is the absolute fastest way to blow out a lumbar disc.
It's a recipe for disaster.
The data from the Family Caregiver Alliance confirms this entirely. The sheer physical strain results in devastating injuries for the caregiver.
Like what kind of injuries?
Pulled muscles, strained lower backs, and severe joint damage. But it's also incredibly hazardous for the passenger.
How so?
We are often dealing with individuals experiencing orthostatic hypotension, which is that sudden dizziness you get when you stand up too fast.
Oh, right, when all the blood rushes from your head.
Exactly. We're also dealing with neuropathy, where they can't fully feel their feet on the pavement. We're dealing with post-surgical weakness and general confusion.
So what happens when someone with dizziness freezes up halfway into the car? They panic, their body goes rigid, or worse, their knees just buckle.
And the caregiver, who is operating purely on adrenaline and love, tries to catch them.
And that is how both of them end up on the pavement with fractures.
Precisely. And this brings us right back to your IT analogy of the single point of failure.
The server crashing.
Right. What happens to the network when the server crashes? When a caregiver herniates a disc trying to lift their father into a Honda Civic, the entire fragile care ecosystem collapses instantly.
Wow, yeah, the caregiver is now a patient themselves.
Exactly. Who is taking the father to dialysis now? Who is cooking the meals?
That is genuinely terrifying, because there is no backup system in place for most of these families.
None at all.
But even if we assume a best-case scenario even if the caregiver is incredibly fit and somehow manages to avoid a physical injury for years, the logistical toll is still going to cause a massive systemic failure elsewhere.
Oh, absolutely. And that failure usually happens at their place of employment.
Right. Let's talk about that collision between caregiving and career.
It is profound. The AARP report highlights that a massive percentage of these 63 million caregivers are actively in the workforce.
They're trying to do both.
They are trying to harmonize the rigid, highly corporate structure of modern employment with the chaotic, entirely unpredictable demands of chronic illness.
Let me ask you, the listener, to run a quick thought experiment right now. Look at your current job, your current boss, and your current deliverables.
Really picture it.
How long could you maintain your standing at your company if you had to arbitrarily disappear every Tuesday from 1:00 p.m. to 4:00 p.m. and every Thursday morning?
It wouldn't take long.
How long before you get pulled into a one-on-one meeting with HR?
It creates this insidious, invisible drain on a person's career trajectory. Caregivers aren't just missing work, they are hemorrhaging their long-term financial security.
Because they're small, right?
Right. They burn through their vacation days first, then they exhaust their sick leave, then they start taking unpaid days.
And it escalates from there.
They have to decline business trips, they turn down overtime, they back out of high-visibility projects because they know they can't guarantee they'll be at the final presentation if their mother's appointment gets rescheduled.
Which means they miss the promotion, which means they miss the salary bump, which means they lose out on the compound interest of increased retirement contributions over a decade. The hidden financial math of being a caregiver is just devastating.
And management rarely sees the full picture. They don't see the heroic effort happening behind the scenes. They just see an employee who is suddenly unreliable or distracted or not a team player.
Let's talk about that distraction, because the brain drain is real. Imagine you are that caregiver. You are sitting in a massive strategy meeting at 2:00 p.m.
Right.
But your brain isn't processing the quarterly projections on the whiteboard at all. Your brain is running a terrifying logistical simulation.
You're doing math in your head.
Exactly. You are looking at the clock, wondering if your dad's oncology appointment is running late. You are calculating the traffic on the interstate.
Checking your phone under the table.
Yeah, trying to figure out if you can seamlessly slip out of the meeting, drive across town, load the wheelchair, get him home, make him a sandwich, and still get back to your laptop to answer an urgent client email by 5:00 p.m.
That state of constant low-grade neurological panic is what researchers document as chronic caregiver stress. It literally floods the body with cortisol.
You're just bathing in stress hormones.
You are never fully at work, and you are never fully at rest. You are perpetually bracing for the next logistical failure.
So we have established that this system physically breaks bodies, torpedoes careers, and destroys financial stability.
Pretty thoroughly, yes.
The obvious question any rational person would ask is, why don't they just ask for help?
It seems like the logical next step.
If I am drowning, I yell for a lifeguard. Why do these families keep doing this entirely alone until they physically or financially snap?
Because human relationships aren't rational, they're deeply emotional. And this brings us to one of the most painful psychological barriers detailed in the SwiftAid transport analysis.
What's that?
It is the guilt trap.
Ah, the guilt trap. Like, if I really loved my parent, I would take them to the doctor myself.
That is the exact internal monologue. Caregivers view outsourcing the physical logistics of care as a moral failure on their part.
They feel like they're failing.
They think, what kind of son am I if I can't even drive my own mother to her infusion? They made promises perhaps years ago when everyone was healthy, saying, Dad, I promise I will always take care of you.
And they hold themselves to that literally.
Yes, they conflate the physical act of driving a car with the emotional act of loving their parent.
And society just completely reinforces this.
Oh, absolutely.
We valorize the martyr. We applaud the person who sacrifices absolutely everything, but we don't look at the wreckage it leaves behind.
The irony is that this guilt creates a highly toxic cycle that ultimately harms the very person they are trying to protect.
Wait, how does it harm the patient? Let's look at this from the patient's perspective, because the dignity deficit here is massive.
It really is. Like, put yourself in the shoes of the passenger for a moment. You are an adult. You have lived a full life. You raised a family. You had a career.
You were independent.
Right. Now, your body is failing you. And every week, you have to watch your exhausted, stressed out daughter frantically checking her phone, rushing you out the door, and struggling to physically lift you into a car in a public parking lot.
It's humiliating.
You can see the dark circles under her eyes. You know she is missing an important meeting at work because of you.
The psychological toll on the patient in that scenario is immense. No parent wants to be the source of their child's suffering.
Nobody wants that.
They begin to feel like a massive burden. They stop feeling like a father or a mother, and they start feeling like a chore, like a very heavy box that needs to be moved from point A to point B.
And the data shows this leads to incredibly dangerous behavior on the patient's part, right?
It does. Patients will actually hide their symptoms.
They will downplay their pain or literally cancel their medical appointments in secret, simply because they cannot bear the guilt of asking their son or daughter to take another afternoon off work to drive them.
That is so sad and so dangerous. This is where the single point of failure completely crashes the system.
Let's trace that cascade.
Okay, so the caregiver is too overwhelmed to manage the logistics perfectly.
Right, which means the patient feels guilty and hides their needs.
Which leads to appointments getting delayed or entirely missed.
Which means the underlying medical condition rapidly worsens.
And suddenly, the family isn't dealing with a routine clinic visit. They're dealing with an acute emergency room admission that could have been entirely prevented.
Exactly, a preventable crisis. The CDC and the National Institute on Aging are very clear about this in the resource material.
What do they say?
Taking care of the caregiver actually implementing structural support systems is not a luxury. It is a medical necessity.
Because you can't sustain the patient without sustaining the caregiver?
You cannot sustain a patient's health if the mechanism delivering them to the doctor is broken. Telling a family to just feel less guilty doesn't work.
No, you can't just wish away guilt.
You cannot solve a structural logistical crisis with emotional platitudes. You have to introduce a reliable, professional mechanism that fundamentally changes the equation.
You have to change the system.
Yes, you have to allow the family to step back from the dangerous physical mechanics without stepping away from the emotional support.
And that is exactly where the concept of non-emergency medical transportation comes in. NEMT. Let's really break this down because I think a lot of people misunderstand what this actually is.
I agree. NEMT is the structural solution to the transportation bottleneck. To define it clearly based on the Centers for Medicare and Medicaid Services framework.
Okay, let's hear the official framework.
NEMT is designed for individuals who are medically stable, meaning they do not require acute medical intervention, life support, or a siren during the ride.
Right. If it is a heart attack, you call 911 for an ambulance.
Obviously. But NEMT is for patients who cannot safely or practically utilize standard transportation, like a family car, a city bus, or a standard rideshare app to access their covered healthcare services.
I want to highlight that rideshare comparison for a second because someone listening might think, why don't I just call a ride-hailing app for my dad? It's cheap, it's easy.
It's a very common thought.
But think about what we just discussed regarding the biomechanics of transferring a patient. A random driver in a Prius has zero training in how to safely pivot a person with orthostatic hypotension.
Not at all.
They don't know how to properly collapse a bariatric wheelchair, let alone secure it inside the vehicle.
Not to mention, a standard rideshare is curb to curb. They pull up, you get in, they drop you off at the curb.
Good luck getting from the curb to the clinic on the 4th floor.
Right. NEMT provides door-to-door or even hand-to-hand service. But the true paradigm shift outlined in the text isn't just about the physical vehicle.
What is it about?
It's about how NEMT redefines the family dynamic.
This is the line from the source material that absolutely stopped me in my tracks.
Oh.
I love this. It says, a daughter should be able to be a daughter, not only a driver.
It is a brilliant distillation of the problem.
Think about the mental liberation of that concept. If you are that exhausted daughter, you no longer wake up on Tuesday morning with a pit of dread in your stomach, trying to calculate the physics of getting a wheelchair down a snowy driveway.
That dread is gone.
You wake up and you think, we have a professional team for this. The logistics are handled. And because your brain is no longer consumed by traffic patterns and lifting mechanics, you actually have the emotional bandwidth to be present with your parent.
That is the ultimate paradox of the guilt trap.
Explain that.
Families think that outsourcing the drive means they love the patient less. But the reality is, outsourcing the grueling physical labor allows you to love them better.
Wow. Yes.
When a husband isn't sweating, out of breath, and dealing with a spasm in his lower back from lifting his wife into the car, he can actually sit next to her in the waiting room and just hold her hand.
He can actually listen to the doctor.
He has the cognitive energy to listen to the oncologist, take clear notes, ask intelligent questions, and act as a true medical advocate. NEMT removes the logistical noise so the signal of love can actually get through.
That is so beautifully put. But let me play devil's advocate again, because practical reality always rears its head, right?
Of course.
If I'm listening to this, I'm thinking, this sounds amazing, a professional team with specialized equipment. But this has to be astronomically expensive. How does a family that is already facing financial strain afford private medical transport every single week?
That is the most common barrier to entry, but it's based on a fundamental misunderstanding of how healthcare funding works in this space.
Okay, enlighten us.
While private pay is always an option, NEMT is deeply integrated into the healthcare reimbursement system. For individuals on Medicaid, NEMT is historically a mandated benefit.
Mandated.
Really? Yes, because the government realizes that paying for a ride to preventative care is vastly cheaper than paying for an ambulance and an ICU stay when the patient's health collapses from missed appointments.
The math makes sense, but what about people not on Medicaid?
Medicare Advantage plans have increasingly recognized this exact math.
Oh, interesting.
Many Medicare Advantage plans now offer NEMT benefits, covering a specific number of trips per year to approved facilities. Furthermore, many specialized clinics like dialysis centers or adult day health programs coordinate and sometimes even subsidize transportation.
Because their business model relies on patients actually showing up.
Precisely. The funding mechanisms exist. Families just need to know to ask the facility's social worker or their insurance case manager about them.
So if the funding can be navigated, let's talk about the actual experience. How is an NEMT provider practically different from that panicked, rushed family experience we detailed earlier?
It comes down to two main things: specialized equipment and specialized training. Let's look at the vehicle first.
Okay, the vehicle. We talked about the danger of a low sedan earlier.
Right. An NEMT vehicle, such as a modified medical van, is equipped with hydraulic wheelchair lifts or specially engineered ramps with specific low-grade inclines.
So no more lifting.
None. Once inside, the vehicle utilizes a 4-point tie-down system to lock the mobility device directly into the chassis of the vehicle, along with a specialized shoulder and lap belt for the passenger.
So the patient never has to leave their customized wheelchair.
Never. The risk of transfer injury is entirely eliminated.
That is huge. And what about the personnel?
The drivers are trained in defensive driving specifically for fragile loads.
Meaning they drive differently.
Meaning they brake and accelerate differently than you or I would in regular traffic. They also are trained in passenger assistance techniques, understanding body mechanics, so they can assist someone who uses a walker without throwing off the patient's center of gravity.
That takes real skill.
And fundamentally, they operate on a different clock.
A different clock.
They understand that rushing a patient with cognitive decline or physical instability is the primary cause of falls and anxiety. Patience is literally part of the service.
That concept of not rushing is massive. When you are physically unstable, feeling rushed is terrifying. So let's make this actionable for the listener.
Let's do it.
If a listener recognizes their own family in this deep dive, and I'm sure many do, and they realize they need to build this support system, how do they assess what they actually need?
The source material provides a brilliant framework for assessing this, and it requires moving past a simple yes or no and looking at real-world scenarios.
Right.
Families need to evaluate 5 specific vectors.
5 vectors. Okay, what's the first one?
First is mobility status. We aren't just asking if they can walk. We're asking, do they require a cane, a standard walker, a heavy rollator, a manual wheelchair, or a 300-pound motorized chair?
Because each one of those requires different vehicle accommodations.
Exactly. You can't put a motorized chair in a standard trunk.
Right. And the second vector is medical stability during transit.
Correct. The family needs to be deeply honest about the predictability of the patient's condition. Can the patient tolerate a 30-minute ride without requiring supplemental oxygen adjustment or acute medical monitoring?
What if they have dementia?
If they have severe dementia, will they try to unbuckle themselves and open the door on the highway? The provider needs to know this.
The third vector is fascinating to me because it's something healthy people almost never think about, which is postural needs.
Posture is critical. Let's look at a scenario. Imagine a patient who just had a total hip replacement.
Ouch, okay.
Their orthopedic surgeon will give them strict hip precautions, one of which is usually that they cannot bend their hip past 90 degrees.
So what happens if you put that patient in the back seat of a standard compact car?
Their knees are going to be higher than their hips, breaking the 90-degree rule and risking a total dislocation of the brand new joint.
Which means they end up right back in the OR.
Exactly. Or consider someone with severe spinal kyphosis.
What's that?
It's a pronounced forward rounding of the back. They physically cannot lay flat, nor can they sit perfectly upright against a stiff seat back.
Oh, that sounds so painful.
NEMT providers can accommodate stretcher transport with elevated heads or accommodate customized tilt-in-space wheelchairs that keep the spine perfectly aligned during transit.
Wow, the level of customization is incredible. So the fourth vector is the level of physical assistance required at the origin and destination.
Yes. This is the difference between curb to curb and door through door. If a patient has macular degeneration and can't see the curb well, they don't just need a ride.
What do they need?
They need an arm to guide them down the porch steps, through the clinic lobby, and directly to the check-in desk.
And finally, the fifth vector, accompaniment and logistics. Does the family caregiver want to ride along in the vehicle so they don't have to drive separately?
Right, and what is the exact nature of the appointment? A standard checkup has a pretty predictable end time.
But an oncology infusion.
That could take 2 hours or it could take 6, depending on how the patient's blood work looks that day.
So the transportation provider has to have the logistical flexibility to manage that unpredictability without leaving a fragile patient stranded in a waiting room for hours.
Exactly. And this framework ties perfectly into how SwiftAid Transport approaches this entire industry. They don't view themselves as a taxi service.
No, they view themselves as an extension of the care team. They center their entire operational model on the concept of dignity.
Dignity is the true antidote to the psychological guilt trap we discussed earlier.
It really is. SwiftAid's approach means speaking directly and respectfully to the passenger, not talking over them to the caregiver.
That happens so often.
It means allowing ample time for the transfer so there are no jerky, rushed movements. It is about offering physical support in a way that empowers the patient, rather than making them feel helpless. They treat the passenger as a respected human being, not just a package on a delivery route.
And for the family caregiver, integrating a service like SwiftAid allows them to retain control without breaking their backs. The family is still in charge.
They still run the show.
They coordinate the schedule, they communicate the specific medical nuances to the dispatcher, they can meet the patient at the doctor's office, and they handle the medical decision-making.
They outsource the heavy lifting, but they retain the advocacy.
The overarching lesson here, whether we look at the CDC guidelines, the National Institute on Aging data, or SwiftAid's specific model, is about proactive architecture.
You don't wait for the IT server to catch fire before you buy a backup drive.
Exactly. Families cannot wait until the caregiver has a ruptured disc, a burned-out bank account, or a final warning from HR before they ask for help.
Building a care system early on is the only sustainable way to manage chronic illness.
It shifts the entire family narrative. It moves from the isolating, crushing belief of, I must do this all myself to prove my love,
To the deeply empowering realization of, I am managing a care team and I have partners.
That's the shift.
Well, we have covered a massive amount of ground today, peeling back the layers of a system most people never see. So let's summarize the true journey of the family caregiver.
Let's bring it all together.
They are the invisible, overworked, and exhausted backbone of healthcare access in this country. They take on this immense burden out of profound love.
But relying purely on love to overcome complex logistical, physical, and financial barriers is a recipe for systemic collapse.
It inevitably leads to severe physical injuries for both parties, deep financial instability, missed medical care, and a tragic cycle where the patient feels like a burden and loses their dignity.
But the transportation bottleneck is a solvable problem. Non-emergency medical transportation is the missing structural link.
By bringing in a professional, fully equipped, and compassionate transportation team, families achieve multiple victories at once. The patient gets a perfectly safe, medically appropriate ride.
The caregiver protects their physical spine and their career trajectory.
And most importantly, the dignity of the patient is preserved.
NEMT does not replace the family. It fortifies the family. It provides the exact structural support needed so that love can actually thrive, rather than just barely surviving the Tuesday morning logistics.
So, to you listening, whether you are that exhausted daughter gripping the steering wheel, a patient dreading your next appointment, or a healthcare administrator trying to reduce your clinic's no-show rate, we want to explicitly share SwiftAid Transport's message with you.
They are actively working to be that vital pillar of support in your care system.
They provide the reliable, compassionate, and transparent medical transportation that breaks the cycle of burnout.
Having a dedicated professional partner fundamentally changes the landscape of aging and illness for a family.
If you are ready to build that support system, or if you just want to understand your options, reach out to them. They can help you navigate the logistics. You can email their team directly at support@swiftaidtransport.com.
You can also call them to discuss your specific needs at 973-315-600.
Or you can explore their services online at www.swiftaidtransport.com. Again, that is support at swiftaidtransport.com, 973-315-6000, or www.swiftaidtransport.com.
As we close out this deep dive, I want to leave you with a broader philosophical question to reflect on. We have spent this time thoroughly examining how outsourcing the grueling physical logistics of medical transportation actually increases the emotional quality of the care you can provide.
Right. By stepping back from the mechanics, you make room for true human connection.
So look at the rest of your life. What other duties of love are you stubbornly clinging to, utterly convinced that you must suffer through them yourself, that are actually preventing you from truly being present with the people you care about?
That is a powerful reframing. Sometimes the absolute best way to show up for someone you love is to let someone else do the heavy lifting. Until next time.